So first of all, I would like to thank Harry Hansen and Adam Gehring for the invitation to give this talk on the potential of new combinations to achieve functional cure for chronic hepatitis B. Here you see my disclosures. As you all know, there are major barriers to functional cure of HBV infection, which mainly rely on the fact that the viral genome persists as a form of covalently closed circular DNA or cccDNA, which has a long half-life in the nucleus of infected cells and is not affected by nucleoside analogues and interferon. The second very important point is that in chronically infected patients, we observed effective immune responses, mainly of HBV-specific CD8 positive cells and HBV-specific B cells. There is also a weak innate immune response in those patients. So the current concept is that we will need to have a combination of direct-acting antivowels and immune modulators to combat HBV and increase the rate of functional cure. We are very fortunate now that we are in a very exciting time of HBV research because we have drugs that have entered clinical trial development, and we are not talking about only preclinical data, we are talking about clinical trial results. So we have emerging treatment targets that either target directly the viral replication, and we can have concepts which are curative approaches which target the pool of cccDNA in the liver of infected patients that may cure the infected hepatocytes. There are other targets controlling the pre and post cccDNA steps of the viral life cycle, including entry inhibition, targeting viral RNAs, capsid assembly modulators, and inhibitors of HBs antigen release. The second aspect, as I mentioned before, is that we have strategies to boost the immune responses that may rely on the stimulation of innate immunity that may express antiviral cytokines that may cure infected hepatocyte, but also strategies to stimulate adaptive immunity that may lead to specific hepatocyte killing, viral neutralization, but also antiviral cytokine responses. So we will see how we can combine all these different approaches to increase the functional cure rate in our patients. Besides these drug discovery efforts, there are also efforts to discover novel biomarkers that will be very important for the evaluation of the new drugs in clinical trials. So beside the classic viral load assays, we have quantitative HBs antigen, which is really the major clinical endpoint because it is associated with a strong clinical outcome. The caveat with HBs antigen is that it is expressed both from cccDNA and integrated viral sequences. So there are other novel biomarkers that are being evaluated, which are circulating viral RNA and mainly pregenomic RNA and HBC-related antigen, which are thought to be currently more relevant for the evaluation of the transcriptional activity of the cccDNA pool in the liver. So these biomarkers are important not only to assess target engagement of the new drugs in the clinic, but also to predict the endpoint of HBs loss. So this will be very important for the evaluation of the combination trial. So as I said, I mean, these different drugs that have been developed recently have now entered clinical trials, and we have very exciting results on the first combination trials. And as you can see, we have these drugs that belong to different classes. Several drugs inhibit viral replication. Some inhibit viral antigen expression. And regarding immune stimulation, we have drugs that aim at invigorating immune responses. and approaches such as therapeutic vaccine that aim at stimulating HBV-specific B and T cells. So you see that we have quite a lot of drugs and strategies that may be combined to increase the rate of functional cure. So we'll show you some example of recent clinical trials. So here, as a first example, is whether we can combine direct-acting antivowel to increase vowel suppression and maybe obtain a functional cure just with antivowels. So there are attempts using nucleoside analogs and capsid assembly modulators that have been recently published. So there is quite a lot of interest and excitement with the development of capsid assembly modulators that you have seen in the last couple of years, with drugs that show in phase 1b a very nice decline in HBV DNA levels by approximately 2 to 4 logs in these trials. And this was accompanied by a decline also in pregenomic RNA in serum. But there was no effect on HBs antigen in this very short-term trial. Now there is some longer experience with longer administration of capsid assembly modulators in combination with nucleoside analog. And you see one of the examples of this combination therapies that have been presented at the latest EASL meeting. And you see that with Vebicovir, after 72 weeks of administration, you see a very strong decline of HBV DNA when it's administered in combination with entecavir by approximately 7 log, which is really impressive. And it is accompanied by also a decline in pregenomic RNA in serum, which is consistent with the mode of action of Vebicovir, the capsid assembly modulator. When you look at the effect of this combination of entecavir and Vebicovir on the biomarkers that I just alluded to, you see a decline in pregenomic RNA in serum of HBC-related antigen as well as HBs antigen in some patients. So we are in a situation where we can really ask the question whether a combination of Nuke plus a capsid assembly modulator may be sufficient to achieve a functional cure with longer-term administration, or whether at some point when all the biomarkers would be undetectable in serum, we could stop treatment and see whether we could maintain vowel suppression or even achieve a functional cure after treatment withdrawal. Now moving to other type of combination of direct-acting antivowels, we have seen results of a combination of nucleoside analogs and approaches to decrease antigen expression, mainly with siRNA and antisense oligonucleotides. Here you see the results of clinical trial combining nucleoside analog and siRNA from J&J, which was earlier on developed by Arrowhead. And you see that in that phase 2 study presented at EASL, 40 patients on Nukes received 3 administration of the siRNA, which led to a decrease of HBs antigen in the vast majority of patients. More than 1 log decline was observed. And it was interesting to see that 15 out of 38 patients, so 40% of patients, were responder throughout the study and maintained the decline of HBs antigen through the whole study until day 392, which is really interesting and will pave the way for future evaluation in a very near future. Another approach is to combine a Nuke with an antisense oligonucleotide. And this was presented again at EASL. This was developed by GSK. And you see that in that study, there were patients who were nucleoside analog naive or patients who were already virally suppressed and received the antisense oligonucleotide. What is interesting is that 80% of the patients have seen an HBs antigen decline by more than 1 log, which is very impressive at such stage of clinical development. And 4 patients, those with an asterisk, had an HBs loss at day 29, and 2 of them remain undetectable at the end of the study. What was interesting to see is that the magnitude of HBs antigen decline was higher in patients with ALT elevation, and we'll have to see whether this was due to some kind of immune restoration. Another type of combination of direct-acting antiviral is a triple combination, so a Nuke, a capsid assembly modulator, and an siRNA. And this was presented last year at the AASLD by J&J and MFUN, who showed that this first proof of concept study in patients receiving this triple combination showed a robust reduction in HBs antigen, HBV DNA, and HBV RNA. So all patients achieve a more than 1 log decline in HBs antigen, and this decline was similar in HBe positive or negative patients. So this is really a first study with this type of triple combination of direct-acting antiviral, and then we will see whether this will be sufficient to cure infected patients or whether we will need something else, so an approach combining an immune modulatory strategy. So we come here to combination trials having an antiviral with a strategy boosting innate immunity. So the first attempt was with the use of an entry inhibitors, Mircludex, together with interferon in chronic hepatitis delta. So we showed interesting results on HDV RNA, but here looking at the effect on HBs antigen, what was remarkable is that 40% of patients had a more than 1 log decline of HBs when they received a 2 milligram Mircludex plus pegylated interferon. So we will have to keep this in mind for patients who are monoinfected with HBV for future clinical trials. Another combination trial was using Tenofovir with an HBs antigen release inhibitor, a nucleic acid polymer with interferon, and it was recently published in Gastroenterology. This approach developed by Replica showed that 35% of patients had a functional cure 48 weeks after treatment cessation, which is something that is very remarkable and promising, so we'll have to see how it holds on the long term. Another approach with antiviral and innate immunity boosting is a combination of a Nuke with a TLR8 agonist, which was shown recently in a phase 2 study at EASL, showing a very good safety profile and a modest decline in HBs antigen levels. So we'll have to see whether in the future this could be a backbone for a combination with other direct-acting antivirals or immune modulators to increase the rate of HBs antigen decline. Lastly, the combination of a therapeutic vaccine to stimulate HBV-specific T cells or B cells has been evaluated in combination with Nuke, and we know that it was a little bit disappointing. So the investigators went on to a triple combination in association with a checkpoint inhibitor like an anti-PD-1 such as nivolumab. And you see here the results that were published recently by Edgain and Gilead, showing that with a combination of single dose of nivolumab and a T-cell vaccine, you can see some decline of HBs antigen level in that combination. And in that trial, what was interesting is that a single patient lost HBs antigen, but he was in the arm receiving the Nuke plus nivolumab, but not the therapeutic vaccine. So we'll have to learn from these studies and see how we can move forward in terms of clinical development for this type of triple therapy. Another approach, which has not yet been studied to my knowledge in patients, is the antigenic reduction with an siRNA and a therapeutic vaccine. This has been studied in a preclinical model, so in transgenic mice which were treated with siRNA and received a Primeboost vaccine. And in that strategy where HBs antigen level were suppressed by the siRNA, the vaccination was very effective, and HBS loss and HBS seroconversion was observed. So now we have all the tools to evaluate this type of approach now in clinical trials, as siRNA and therapeutic vaccines are available. Now, when we have seen all these different approaches, what can we do in terms of clinical development? We can combine replication inhibitors, antigen expression inhibition, and this may be sufficient eventually to cure the infection, or we may be in a situation where we need to combine with strategies to invigorate immune responses or even stimulate these responses. So we'll have to see how we can combine this in clinical trials. And there are several ways to address that issues, and we have learned a lot from the oncology field, which use platform trials where we can use a single infrastructure with different strategies that are evaluated over time with a common control arm to aid in efficiency. However, we should not forget exploratory trials with small group of patients belonging to different phases of the disease to investigate different treatment regimens that may be relevant to one or the other phase of the disease. So these different type of strategies need to be explored in the future. So in conclusion, I hope I showed you that there are some promise from the early phase clinical trials combining different approaches that showed HBS decline. We'll need larger groups of patients and longer follow-up to assess the rate of functional cure and its sustainability. And we'll have also the need to validate biomarkers to predict functional cure, to speed up clinical development, and see whether these biomarkers can help us in response-guided treatment cessation. As I said, disease and patient heterogeneity will need to be considered in the development path of these combination studies, as well as the need for better assessment of responses on the cccDNA reservoir and the immune restoration. We should also support ongoing drug discovery effort to feed the drug pipeline that will be needed to have improved combination therapies. With this, I would like to thank you for your attention. I'm ready to take questions.